Good evening, everyone. Today we're going to be talking about HLH, which stands for Hemophagocytic lymphohistiocytosis. So, this disease entity is one of uncontrolled immune activation. Think of it as your immune system that has sort of undergone haywire and lost its off switch, wherein the NK cells and the cytotoxic T lymphocytes have lost the ability to take out dysfunctional macrophages. Okay. So we're gonna start with kind of the pathophysiology, and because everything sort of lies downstream to cytokine storm that we see, which is also seen in like macrophage activation syndromes. So let's get started. So let us say there is an antigenic stimulus that activates an antigen presenting cell, and this releases IL-12 and IL-18. Okay, and these activate your cytotoxic, like your CD8 cells, like cytotoxic T lymphocytes, and your NK cells. Okay, and they release interferon gamma, which is the main cytokine that activates macrophages, right? And as you know, a large part of all the macrophages in your body happen to be in your liver, right? Spleen and bone marrow. Okay. Now, sorry about that. When CD4 and NK cells and CD8 cells activate macrophages. Macrophages release four main cytokines that are that underlie everything that happens in HLH. The first one is tumor necrosis factor alpha. The second one is IL-6. The third one is IL-1 beta. And the fourth one is CXCL9. Okay. Now, we're gonna go a little bit more systematically so that y'all don't lose track of everything that's going on here. I'm gonna start off by actually taking a little bit of a detour and then coming back to the pathogenesis, because I think that's going to help everybody follow along more easily. Now, you wanna know that there are 5 out of 8 criteria that need to be met for a patient to be diagnosed with HLH. The first one is bicytopenia, which is anemia and thrombocytopenia, and in some cases neutropenia as well. But mainly anemia and thrombocytopenia is what you need to remember. Fever, splenomegaly, hypertriglyceridemia, hyperferritinemia, decrease in fibrinogen, so hypofibrinogenemia, an elevation of a marker which is CD25. I will tell you more about it soon. And then there is the bone marrow aspirate, which shows phagocytosis, and that's kind of where the name comes from. Okay, so let's get back to our cytokines and what they're up to in this disorder. let's start with tumor necrosis factor alpha. Okay, let's start with tumor necrosis factor alpha. So what this guy does is that activates CD4 helper T cells, which releases IL-2. Now, this cytokine is the one that activates cytotoxic T lymphocytes all over again. And then what happens is there is this receptor on top of the cytotoxic T lymphocytes, which is the soluble IL-2 receptor. Okay, this is what we call CD25. Now, when this gets activated, this receptor sort of falls off, right? And it's in the blood, and that's how it acts as a marker of a marker for diagnosis of a marker of inflammation, and it aids in the diagnosis of HLH. Now, why is this important? Why do we need to understand why this thing is falling off? It's because it sort of acts as a sink for IL-2. It's trying to temper down the inflammation by binding IL-2 and reducing the inflammation, and it also acts as a marker, so that's pretty cool. Now, let's move on to the next thing that TNF alpha does, right? I'm going to change the color a little bit so we can have a little, it's a little bit easier on the eyes, otherwise everything just looks the same and it's more confusing. Tumor necrosis factor alpha inhibits lipoprotein lipase, and that leads to increased VLDL, and this is what causes the hypertriglyceridemia. Okay, and the hypertriglyceridemia is it's like 300 to 500 in most cases, and sometimes in extreme cases it's like more than 1,000, which is a lot. And we know from like the boards that this can actually be a trigger for pancreatitis, just to tie that in there. Now, let's move on to IL-6. Right, now IL-6, as you have learned in the boards, is what causes fever, right? It's one of the cytokines that's responsible for fever. But another important thing that it does is that it upregulates hepcidin, right? And this is what is causing your liver to sequester iron, and that is what underlies the hyperferritinemia that we see. Now, hyperferritinemia also is both a marker and a mediator of inflammation, because it again goes back to activating the macrophages, but then it also is a marker in the sense that in most cases it's going to be more than 500, but we've also heard of it going up to like 10,000 and 15,000, which is a lot, right? So that's like extreme hyperferritinemia. Now, IL-2 here is one of the cytokines, like IL-2 as well as IL-6. They both also cause endothelial activation. And this is what causes kind of like the platelet consumption. It's sort of tying into the bicytopenia, which is when the macrophages like start eating up blood cells, right? And you have the anemia and thrombocytopenia. And this also causes like the consumption of platelets and like this DIC plus shock kind of picture that can be seen with HLH. Now, moving on to CXCL9. I'm going to change the color again so it's a little bit easier to follow along. The blue is not good enough. We have too much blue already. Let's go with purple. Okay. CXCL9 recruits CD8 cells, and that again makes interferon gamma, which goes into, so you're seeing how everything sort of goes back to sort of activating the macrophage, or like causing increase in cytokines either directly or indirectly, and you're sort of caught in a loop where there's no off switch. Like NK cells, which are supposed to take out macrophages that are malfunctioning, are not doing that job anymore, and then your immune system is just going haywire and going on producing cytokines and going on causing the cytokine storm, which causes end organ damage. And that's pretty much like the gist of the way that things go in HLH, and that's an important thing to remember. Now, let's go back to the list that we saw here, right? And let's start ticking off the things that we already went over and we understand. And if we've missed anything, I will elaborate. Now we have the bicytopenia, which is the byproduct of the macrophage getting activated and eating up the blood cells, and that's also why you see the phagocytic picture in the bone marrow aspirate, right? We have the cytokines, which are causing fever. Macrophages are also present in the spleen, and this causes splenomegaly from macrophage activation. We have the hypertriglyceridemia, which is coming from TNF alpha inhibiting the lipoprotein lipase, and sort of there is also like an increased there's an upregulation of like lipid production itself in the liver also, and the hepatic dysfunction here is something that it contributes to the hypertriglyceridemia. We know the hyperferritinemia because of the IL-6, and then hypofibrinogenemia. Okay, that is the one thing that I did not elaborate on. So another thing that you need to remember is that macrophages, they activate tissue plasminogen activator, and then this activates plasminogen to plasmin, and this is what like sort of degrades fibrin clots, and also it can directly degrade fibrinogen, right? And that is what causes like the fibrin degradation products to be increased in HLH. So this is also causing like an increased bleeding tendency, which sort of ties into what we saw earlier with the endothelial activation and the hypofibrinogenemia. So this is the basis and like sort of the pathogenesis of HLH. Usually this happens obviously with an ICU level of care. You wouldn't the patient obviously wouldn't be hemodynamically stable enough to be on the floors. If you ever come across a patient with HLH, like if you're seeing it in heme, it's probably going to be a consult from the ICU to see this patient, because the patient is in shock at this point, and the mortality is pretty high. But I think if it is caught early and managed appropriately, there is hope. But it still happens to be one of these sort of rare, like a zebra case, where you're always worried about mortality because of how severe the immune activation and the cytokine storm can be, and then that goes on to cause end organ damage. I hope this was helpful in sort of trying to see how it presents, and sort of how that would tie into a board question either for the US MLEs or for the IM boards, and the sort of like the clinical vignette that you might come across when a patient comes in with HLH. Thank you so much. I hope you enjoyed the video. I will see you next time. Have a good evening.